Only one candidate is there. So we will start now. So I think all the candidates are here. So there are some rules and regulations. So duration of each paper is 5 minutes. So the presenting author should not be changed, which was sent in the abstract paper. He should be be the presenting author. So we can start the first one. That is pattern and profile of pediatric intermediate uveitis at the tertiary eye care center in post-COVID era. The presenting author is Madhvi Mishra.
Shivangi Kapoor, first presenter.
Okay. Shivangi Kapoor. Okay. Yes, you can speak.
Okay.
Dr. Meghna Panchashik.
She will speak on bacillary layer detachment, prevalence and clinical features in posterior uveitis.
Good morning, everybody. I'll be talking about bacillary layer detachment, prevalence and clinical features in posterior uveitis. There's no financial disclosures. Bacillary layer detachment is a recently recognized OCT finding that describes a split within the inner segments of the photoreceptors, just posterior to the external limiting membrane. So, according to Mehta et al., there are two factors responsible to form Ballard. That is a hydrostatic force from the choroid, which has enough strength to split the photoreceptors, and a space in the zone of weakness of the photoreceptors inner segment myoid within the external limiting membrane and the ellipsoid zone. So retinal acute fluid accumulation is sudden and rapid influx of intraretinal and subretinal fluid. It is said to be more responsible for development of Ballard. Choroidal ischemia is another possible pathogenesis. It is associated with weak age sympathetic ophthalmia, which can also have Ballard. It responds well to steroid therapy. So the aim of this study is to determine the prevalence and clinical features of Ballard in patients of posterior uveitis and to determine its prognostic value. Material and methods was done among 25 patients of posterior uveitis presenting in the OPD at tertiary care center. Inclusion criteria included patients aged more than 18 years with the presence of BD on OCT. Exclusion criteria, patients who were not willing to give informed consents and who had a substantial media opacity. The results, 36 eyes of 25 patients with Ballard were included in the study. Mean age was 49. Mean BCVA was 1.03 according to the logMAR. Mean CMT was 745 micrometers. There was no correlation between the BCVA and the CMT. So this is the graph showing the age and gender distribution of patients of posterior uveitis, which shows that there was the highest was among the age group of 40 to 49 years, and the prevalence of Ballard was the highest in weak age. This is a table showing the prevalence of Ballard in various causes of posterior uveitis, which showed highest in weak age. And the line graph showing the change in the visual acuity of weak age in before and after treatment. So which shows that the patients of weak age without features of Ballard had a better improvement in the visual acuity after treatment. This is the table showing the differences in the average visual acuity at presentation of the patients of posterior uveitis. We show the presentation at presentation almost all the whether with or without Ballard had similar visual acuity. So this is a few of the pictures of our patients. Case of weak age, which is showing the features of Ballard. Case of prostate branch angiitis. Is recurrent multifocal choroiditis, also showing disorganization of inner retinal layers and features of Ballard. Case of tuberculous choroiditis, and also it is seen in a patient of SLE and choroidal osteoma, one patient. So there were different patients diagnosed with VKH, choroidal neovascularization, toxoplasmic retinochoroiditis, prostate branch angiitis, panuveitis, tuberculous serpentinoid choroiditis, and in 6 eyes, the Ballard was located at the macula, and in 2 eyes in the mid periphery. The splitting between the IS myoid and the IS ellipsoid was found in all cases. In 3 eyes, the Ballard was isolated. In 2 eyes, the internal splitting of OPL and outer nuclear layer was noticeable. The follow-up of 6.3 months was available in 7 eyes. Complete retinal flattening took about 14 days. Progressive improvement of the 4 external bands followed in this order: ELM, EZ, and then finally outer segment tips or RP junction. So our study shows results where 5 eyes of VKH with Ballard had visual improvement with resolution of Ballard at 6 months follow-up, and 6 eyes of VKH without Ballard had a better visual outcome with improvement of more than the one without with Ballard. So another retrospective study which was conducted suggested that the median visual acuity at presentation was worse and had longer resolution period of 12 months. Our study suggests that the presenting visual outcome is similar in both sets of eyes. So there are still debates about the real topographic correspondence between the cell histology and the structural OCT images. So the exact location of the splitting in Ballard remains speculative. The splitting might occur at the level of IS myoid within the ellipsoid zone or at the ISOS junction. The limitation of our study was the need for the larger sample size, longer follow-up period to assess the resolution time for complete or partial macular restoration, and to assess the final visual outcome. To conclude, our study suggests that Ballard was observed in series of posterior uveitis like VKH, followed by other causes like toxoplasmic, retinochoroiditis, and tuberculous choroiditis. Presence of Ballard in VKH can be predictor or for a poor visual outcome in comparison to VKH with only SRF. So the diagnosis and differentiation of Ballard from other causes of retinal detachment and retinochisis is important for clinician to determine distinct etiology. Thank you.
Okay, how many days you have given steroids for these patients and which route?
For patients of VKH, we would give, based on their weight, we would start weekly tapering doses, sir, for 3 to 4 weeks.
What was the time of resolution of Ballard after you started steroid? The mean time of resolution?
Sir, around after starting of 3 to 4 weeks, they would start showing some improvement. And
Is there any new entity which was not documented previously in the literature? You find in some case of posterior uveitis for the first time. All cases were previously also reported as having the bacillary layer detachment.
No, ma'am. That we found out on OCT, like what different causes of posterior uveitis, whether they had Ballard or not, that we saw through the OCT imaging that we made, they were not previously diagnosed.
Okay.
Okay,
Next.
next presenting author is Aditya Gandhi. Aditya Gandhi, okay.
Good morning, everyone. The topic of my paper is clinical profile, complications, treatment, and visual prognosis in sarcoid uveitis. Sarcoidosis is a systemic inflammatory disorder of unknown etiology characterized by non-caseating granulomas that primarily affect the lungs and lymphatics. Ocular involvement is seen in around 60% of sarcoidosis cases, of which uveitis is the most common feature, seen in 30% cases. Diagnosis of ocular sarcoidosis is based on the revised AIOC criteria established in 2019. The aim of our study was to determine the clinical profile, complications, treatment, and visual prognosis of sarcoid uveitis in the South Indian population using the revised AIOC criteria. This was a retrospective observational study for a period of 18 months, and we enrolled 94 eyes of 51 patients. We documented the age, gender, symptoms, and a detailed history regarding the onset and progression of the disease. The best corrected visual acuity was measured using a Snellen's 3-meter chart, and we also examined the anterior segment and fundus and noted the intraocular pressure. These were the investigations we did for our patients, and the treatment modalities mainly included corticosteroids, immunosuppressive drugs, cycloplegic agents, and IOP lowering drugs. According to the AIOC criteria, we classified the patients into confirmed, presumed, and probable sarcoidosis, and anatomically into anterior, intermediate, posterior, and panuveitis. The BCVA was measured at presentation 1 month and 6 months, and this value was converted to logMAR for future comparison. In results, we found that 54% of the patients in our study had probable sarcoidosis, 44% had presumed, and 2% had confirmed sarcoidosis. There was a significant female preponderance, with 90% of the cases being female. The mean age at presentation was 48.66 years, and the most common age group affected was 51 to 60 years. The most common symptom observed was defective vision, followed by redness, floaters, watering. Most common anatomical presentation was anterior uveitis, followed by panuveitis, intermediate and posterior uveitis. The most common anterior segment findings were AC cells, keratic precipitates, and AC flare. A few rare findings included band-shaped keratopathy and conjunctival nodules. The most common posterior segment findings were vitritis and vitreous exudates, and a few patients demonstrated periphlebitis, optic disc involvement in the form of optic disc granulomas. The most common complication observed was chorioretinal scarring, followed closely by secondary glaucoma. Other complications included cataract, cystoid macular edema, vitreous hemorrhage. 88% of the patients in our study demonstrated a non-reactive MANTO. 80% had elevated serum ACE, 32% demonstrated lymphopenia, 36% demonstrated features of sarcoidosis on X-ray chest, and 52% demonstrated features of sarcoidosis on CT thorax. The most common treatment modality used was oral steroids, which was used in 96% of the patients. Only 19% of patients in our study needed immunosuppressive agents. There was an improvement in the mean BCVA at 1 month as compared to that at presentation, and this improvement was maintained at 6 months, which was found to be statistically significant. In discussion, significant female preponderance was observed. However, no bimodal peak as reported by other studies was seen. Other studies have demonstrated panuveitis to be the most common presentation. However, in our study, we found anterior uveitis to be most common. Considering the expensive and invasive nature of performing biopsies, majority of the patients in our study were diagnosed using radiological and blood investigations as per the revised AIOC criteria. A higher rate of negative MANTO and elevated serum ACE was observed. Positive findings suggestive of sarcoidosis on radiological investigation was lower than that of 2 studies on Caucasian and Turkish populations and was comparable to that of another study in the Indian population. Requirement of oral steroids was higher and that of immunosuppressive agents was lower. In our study, at the end of 6 months, 21 eyes showed improvement in BCVA and 12.76% eyes demonstrated a decrease in BCVA. This is a table demonstrating a comparison between studies on sarcoid uveitis in different population groups. The strength of the study includes systemic categorization of the patients into by the AIOC criteria and early diagnosis. The drawbacks include a small sample size, shorter duration of follow-up, and lack of biopsy-confirmed cases. Also, being a tertiary care hospital treating only ophthalmic disorders, evaluation of systemic features of sarcoidosis and progression from ocular to systemic disease could not be studied. In conclusion, I would like to say that uveitis attributed to sarcoidosis appears to be underdiagnosed in India due to the fact that India is a tuberculosis endemic country, and both these diseases present with similar ocular features. Given the expensive nature of biopsies, the application of revised AIOC criteria can be used for early diagnosis and treatment of patients with ocular sarcoidosis, which will in turn minimize the incidence of complications and ocular morbidity and aid in prompt referral for systemic workup, since many patients present initially only with ocular features. Thank you.
How will you rule out tuberculosis before starting any? If like 80% you are telling tuberculosis, if 80% is confirmed with tuberculosis, otherwise you are thinking sarcoidosis.
No, sir. According to the revised AIOC criteria, there's criteria. If there's a negative tuberculin test, it points more towards sarcoidosis. That is a diagnostic criteria for sarcoid. So based on the criteria, the patients which fulfill those criteria, we classified the patients into confirmed, presumed, and probable. So as long as there was no definite evidence of tuberculosis, we considered the patients to not have tuberculosis, and if they fitted the criteria, we classified them into sarcoidosis.
That is a very strange thing about sarcoidosis, that when you are treating sarcoidosis, unless you have a biopsy report with you, most of the time these post-viral inflammations also mimic sarcoidosis. So we'll take your findings with a pinch of salt here, because you did not require continuous immunosuppression in most of your patients. So yes, that goes slightly against the diagnosis.
Yes, sir. That is a limitation because our study period was short. Yes, sir.
No, but anyway, good work.
Thank you.
No, that's it.
We can have the next speaker, Dr. Radhika Shriram. Dr. Radhika is here? Yes, sir.
Good morning, everyone. I'm Dr. Radhika, and I'll be presenting our work on changes in the choroidal vasculature due to syphilitic uveitis by calculating the choroidal vascularity index. Syphilis is a great masquerader caused by Treponema pallidum, and in the recent years, there has been a re-emergence of syphilis all over the world. So, the ocular manifestation of syphilis includes acute syphilitic posterior plecoid chorioretinitis, syphilitic retinitis, retinal vasculitis, and also anterior uveitis. Syphilis in the choroid causes choriocapillaritis and also causes angiogenetic changes. So the aim of our study was to determine the changes in the choroidal vasculature in syphilitic uveitis and its effect in the visual prognosis. Our study was a retrospective observational image analysis conducted in a tertiary eye care center in South India for a duration of 3 years. Treatment-naive patients above 18 years of age positive for VDRL and TPHA with a follow-up period of 3 months with pre-treatment and post-treatment EDI OCT scans were included in this study, and a poor quality OCT scans where patients with poor quality OCT scans were excluded. So the pre and post-treatment EDI OCT scans were analyzed using an ImageJ software in which the luminal area, stromal area, total choroidal area were determined, and the choroidal vascularity index is a ratio of the luminal area to the total choroidal area. So first the EDI OCT is selected, and the area of interest, that is the subfoveal choroid, was selected. A polygon of 1500 microns were made. Image binarization was done using NIC-black technique. Brightness and saturation adjustments were done, and the luminal area and total choroidal area were calculated, obtained from this software. So we studied 10 eyes of 6 patients with a median age of 46 years. Of these 10 eyes, 2 eyes had retinitis, 4 had retinal vasculitis, and 4 had chorioretinitis. So the luminal area, total choroidal area, and choroidal vascularity index was significantly reduced in eyes with syphilitic posterior uveitis when compared with the age-matched cohort, as we can see in this box and whisker plot. Post-treatment, when these parameters were analyzed, it showed an improvement compared to the pre-treatment values. Whereas, when we compared these post-treatment parameters with the normal cohort, we found that these parameters, that is luminal area, stromal area, and luminal area, total choroidal area, and the choroidal vascularity index did not revert back to normalcy. When we saw the visual, in association with visual acuity, there was improvement in visual acuity in these patients. With regards to visual prognosis, as the CVI improved, the visual acuity also improved in.
Can we have the slides, please, AVT?
Good morning, everyone. My topic of today's presentation is navigating through OCT biomarkers in posterior uveitis, retrospective study. The inflammatory process of uveitis causes structural and functional modification which can be studied by OCT. The primary objective of our study is to study vitreous, retinal, and choroidal changes, predominantly in posterior uveitis, that is retinitis, toxo, CMV, and Dosen cases. And the secondary objective is its diagnostic and prognostic implication at the molecular level, reviewed through previous review of literature. This is a retrospective study of 50 patients, 30 toxoplasma, 11 Dosen, and 9 CMV retinitis, studied in a tertiary eye care hospital, Kerala, from Jan 2020 to December 2023. Predominantly retinitis was studied with a definite etiological diagnosis based on typical clinical findings, and the STOCT was studied. The cases with medial opacity, pure choroiditis, vasculitis, or intermediate uveitis, and doubtful etiological diagnosis were excluded. A written consent was taken, and EMR and OCT was studied, especially in active and healed cases with a mean duration of 3.4 months were separately analyzed and studied with the SPSS software. The mean age of presentation was 43.4 years, and there was no sex predilection. Coming to the etiological diagnosis, toxo was 60%, which were 30 patients, Dosen 22, and CMV retinitis 9 patients, comprising of 18%. The best corrected visual acuity improved from 6/60 to 6/24, which was statistically significant. In toxoplasma active cases, the posterior hyaloid thickening, loss of demarcation between vitreous and retina, full thickness retinal thickening with back shadowing, which was disproportionate to the retinitis, and hyperreflective of posterior hyaloid, ILM and retina had the most positive predictive values. These are some illustrative cases. In this we can see a full thickness retinitis with no distinct demarcation line between vitreous and retina, and the inner retina had 100% hyperreflectivity obscuring the underlying structures, and adjacent thickened posterior hyaloid with vitreous condensation. There was blockage of outer retina disproportionate to the amount of retinitis and vitreous echoes. In toxoplasma heel cases, hyperplasia of RPE than RP atrophy with retinal thinning was seen, which had a high positive predictive value and which causes a finding similar to the focal choroidal excavation. Coming to a discussion, active vitreous, in toxoplasma cases, we can see vitreous attachment uniformly seen in all cases at the site of retinitis, and the retina in between the lesions were normal. This suggests that the vitreous could be a culprit in the transmission of the tachyzoid. The role of ICAM1 in transmission of toxoplasma has been previously studied in dendritic cells and also in jejunum in vivo study. We suggest that the ICAM can also be a culprit in the transmission of tachyzoids through the vitreous. And in scarred cases, there is a resistance to RPE, which causes RP hyperplasia. The differential distribution of IF1 and gamma, TNF, IFN gamma and TNF alpha has been previously described in studies, which can cause the resistance of RPE to the tachyzoids. This is the RP and this is the retinal Muller cells. The RP is more resistant to tachyzoids. So highly suggestive features are dense vitritis, full thickness involvement with shadowing, disruption of vitreoretinal interface, full thickness atrophy and RP hyperplasia are the highly suggestive findings in toxo, and others are probable findings. In CMV, our cases were more of full thickness involvement than in cavernous type. RP hyperplasia was seen and there was little vitreous involvement. This is a full thickness case, and this is another case of CMV retinitis with vertical stripes in outer nuclear layer. So in healing cases, we could see there was thinning of retina with a resistant or ILM, and there was a substance of retinal layers involving full thickness. And this can be described as a substance and previously described in other pathologies like CNVM, etc. And this is already previously explained in other terminologies in previous studies in CMV retinitis. So highly suggestive features are full thickness retinitis with RP hyperreflective, ILM separation with thinning. In Duchenne, active lesion causes full thickness involvement. But in substance science in Duchenne is different from CMV. It's that there is outer retinal atrophy than a full thickness atrophy in Duchenne as compared to CMV. This is already explained by Gaius as Duchenne mainly involves a local toxic effect on outer retina, which can explain our findings. So limitations of our study is a retrospective study and no ocular fluid analysis was done. So we conclude that OCT act as a nearest to describe the microscopic involvement in posterior uveitis, that is retinitis, and standardization of these findings should be done in typical cases which can be extrapolated to the atypical cases. Thank you.
The question will arise that what is the utility of this study?
Sir, as we know,
I know you want to say that we'll extrapolate it to atypical cases, but see, it's a straightforward diagnosis.
yes, sir.
It's a naked eye diagnosis most of the time. Yes, we can use OCT in these cases, but because of the backscattering, you cannot really analyze the RP and choroid in most of the active cases. So we are talking here only about the inner retinal signs predominantly. So what do you see is the future of your results?
Sir, one thing is that as we see that most of these, as you have told, the retinitis is, which we have explained, is usually clinical straightforward. But the only test we usually have to confirm is like serological test, which is ambiguous in our population, like IgG, IgM, toxo, or CMV retinitis. So this can only, as you have told, add to a case of clinical diagnosis with toxo, because we don't have any other investigation for. That's why we especially took the retinitis cases like toxo and CMV. And also, as you have told, for sure there will be backscattering in here, active cases. So, like we have one more session is that most of these cases like toxo and CMV will also have healing lesions in most of these cases. Both type of healed and active cases can be seen. So, mostly a healing case can be more predictive of these findings than a active case.
But to diagnose and confirm that it is a toxo, it is usually the documentation by laboratory test. They were done in your study?
No, ma'am. That's what I'm telling. That IgM and IgG are, it's not conclusive in our population for a toxo. And this fluid analysis we have not done, which is a drawback.
But when we are suspecting, we usually do this test and then we can start the treatment. Yes. And side by side, we usually do this test.
But usually we do serum tests, no? Then only we'll start
yes, sir. But even if it is positive, in some cases, even if toxo is positive, the features are suggestive of more of a retinochoroiditis like
that is correct only, but how many percentage people was negative and you started the treatment?
We have not done toxo, IgG, IgM in all cases, sir. Okay. Only clinical diagnosis was taken. Okay. Thank you, sir.
Next presenter is Dr. Pranav Saluja.
Should I start? So I'll be talking about my paper presentation is on the clinical demographic profile and treatment outcomes of post-fever retinitis. This is a comparative study before and after the first wave of COVID-19. So post-fever retinitis is an immune retinitis, as we all know, and it occurs between 2 to 4 weeks after a febrile condition. And it occurs with epidemics of dengue, chikungunya, rickettsial infections with seasonal variation. And the resolution occurs with or without treatment, and there is usually good visual recovery. So COVID-19 pandemic caused by SARS-CoV-2 virus, there was decrease in some vector-borne disease during this period, mainly because people were not going out as much, and there was lockdown at that point. And febrile illness, it is a febrile illness with multi-system involvement, which involves the ocular and orbital manifestation. And there has been a study which suggested that there was no difference in clinical presentation and treatment outcome of post-fever retinitis amongst COVID serology positive and negative patients. And the overall, we wanted to study the overall impact of COVID pandemic on the clinical presentation and treatment outcomes. So our research question was that, is there a significant difference in the clinical presentation and treatment outcomes of post-fever retinitis cases presenting before and after the COVID-19 pandemic? It was a single-center retrospective study, tertiary eye hospital in central India. And patients diagnosed with post-fever retinitis were clubbed into two groups, April 2019 to March 2020, which is the main time for post-fever retinitis to occur. And this was grouped as pre-COVID era, because this was before the COVID. And then April 2020 to March 21, this was grouped as post-COVID era. So the diagnostic criteria was fluffy yellow-white retinitis lesion, intraretinal hemorrhages following episodes of fever, and after all the infective retinitis was ruled out. So methodology, we collected the data of the patient, we took history, details of the fever, the time interval between the fever and the diminution of vision. We took fundus photography, FFA, and OCT was done. So in methodology, outcome measures were latent period between fever and diminution of vision, time to presentation, the anterior chamber and vitreous reaction, disc edema, and FFA findings, and also visual acuity and the treatment given and resolution. So routine investigation for uveitis was done, ELISA for dengue, chikungunya, PS for malarial parasite, Vidal, Wheel Felix for rickettsial, and COVID-19 rat test and COVID antibody test. This was not done in all the cases, only in 18 of the 25 cases. We gave oral steroids as a treatment, and we tapered based on the response. One patient with resolving retinitis was not given any treatment. And patients with severe disease were given intravenous dexamethasone for 3 days and followed by oral steroids. So patients with positive Wheel Felix were given oral doxycycline, and retinal neovascularization was seen in 4 cases. In one of them, we gave intravitreal anti-VEGF. So statistical analysis was done, varied tests were done for the parameters. The results were pre-COVID era group had 29 eyes of 19 patients and post-COVID had 40 eyes of 25 patients. Rest of the things were insignificant except for the duration of DOV at presentation, which was 14.21 in the pre-COVID era, and in post-COVID it was around 24.6. So the monthly distribution is around November to March, which is after the monsoon season ends and winter season starts. The other things were that everything, the vitritis, the disc edema, and macular involvement were more seen in the post-COVID era. Even the vasculitis and posterior pole involvement with macular edema on OCT, all were seen more in the post-COVID era, and they were significant. The other finding which was there was that the wheel phallic reaction was positive in 84% of the patients in post-COVID era group as compared to 47% in pre-COVID era group, which suggests a change in the diagnosis of the patients and the results, because usually wheel phallic is not commonly seen in central India. And the rest of the tests were mostly negative in both the groups. And the COVID antibodies were positive only in 2 of the 18 patients which were tested in the post-COVID era group. So COVID was seen not to be related with the change in the presentation. The other thing was that doxycycline was given to 84% on all the patients who had wheel phallic, and only 1 patient who had extensive vascularization, as we've talked about, was given anti-VEGF. So the other thing is that the time to resolution of retinitis was better in the post-COVID era group. This may be related because of the lockdown measures. So the study highlights the disruptions in the healthcare delivery and delayed patient presentations caused by the COVID-19 pandemic. There was higher incidence, as we've talked about, of the positive wheel phallic reaction, higher occurrence of posterior pole involvement, so we should be aware and treat extensively in these patients. The higher involvement of macular and more severe diseases may be due to later presentation in case of during the COVID time, and COVID-19 infection seems unlikely to be the cause of difference. So the strengths were that it was studied variations in presentations and outcomes and in seasonal pattern of PFR and featuring of preceding illness. The limitation was that it was a retrospective nature of study. We were unable to assess COVID antibodies in all the cases. We only did it in 18 cases, and no direct documentation and diagnosing of the illness was done in majority of the cases. These were the references. Thank you.
What was the time period when you collected this data? The pre-COVID data, what is the cutoff period you have taken, and
So
what is
April 20 to March 20, April 2019 to March 2020.
that is your pre-COVID era?
Yes, sir.
And from 1st April
Since
20
March, because the first wave started during that time. After that, for 1 year, we collected the COVID data.
Okay.
Why it's increased, that is, but response is better, you are telling?
No, sir. Actually, the thing is that as we know that it usually heals by itself also, and there has not been a demarcation as such that whether we should give treatment or not. There have been major studies done in Narayan Netralaya which have suggested that doxycycline may be the only treatment which is effective even when they don't give steroids. So in our cases, we usually at our center give steroids, but because of the later presentation, the time period is usually 6 to 8 weeks for PFR to heal by itself also. So because the patient presented late to us, we thought that because of that there was more inflammation in these cases, and we started the treatment also later. But because the time period is 6 to 8 weeks, so they got better also earlier. That is what we thought, according to the study that we found.
One more question.
Because that is,
Is it COVID antibodies giving pseudo positive for wheel phallic test?
it can, sir. We haven't seen that. Maybe that can be
because
possible.
why there is so much
Wheel
drastic
phallic, yes, sir.
increases?
Because we also studied the latest trends during the, we are based in Madhya Pradesh, so we studied the latest trends of the rickettsial infection also. They were not as such highly reported rickettsial infection. The other thing is that wheel phallic is not very specific for the rickettsia also as such.
It is
But
pseudo positive.
yes, sir. But sir, when we gave doxycycline, recently we started also giving only doxycycline. The patients did improve only on doxycycline rather than giving oral steroids with them. So this is the latest development.
COVID also they started giving doxycycline, no, initially?
Yes, sir.
Okay.
Yeah.
Okay, thank you.
Thank you so much.
We can proceed to the next.
Next presentation is Dr. Apurva Ojha.
Hello. Good morning, everyone. I am Dr. Apurva Oja, DNB trainee from Dinanath Mangeshkar Hospital, Pune. Here I am presenting a case of an intermediate uveitis in a pediatric patient. A 7-year-old female child presented to the OPD with chief complaints of firecracker injury in the right eye, with decreased vision and change in the shape of the pupil, and there was redness. And it was sudden in onset, acute in course, and it was on limited period. You can see it in the right eye. In right eye, on examination, vision was counting finger 1 meter and less than 36. Lids and conjunctiva was normal, cornea was clear, and on pupils it was irregular, and posterior synechia was present at 6 o'clock and 11 o'clock. Lens shows complicated cataract. On applanation tonality, pressures were normal, and on dilated fundus examination, grade 4 vitreous haze was present. And left eye, all the findings were normal. Here you can see in the image there is a right eye vitritis present. Left eye were normal. We have advised chest X-ray skull AP view to rule out any foreign body, and she was started on topical steroids along with cycloplegics. On follow-up, there was no foreign body in the X-ray. In right eye, there was a vitreous grade reduced to grade 3, and USG scan was done to rule out the retinal detachment or any other pathologies. On clinical examination, right eye shows long-standing ocular inflammation having vitritis, posterior synechia, and peripheral patch of retinitis. This is the USG image showing the vitreous exudates. On ACT, there is a right eye retinal thickening, and left eye, all the findings were normal. Ocular toxoplasmosis and toxophoresis was suspected and thus referred to infectious disease specialist. All the investigations were done, like toxoplasma IgG, IgM, and HIV ELISA. All the tests were negative. Montauk's test was negative. After the vitritis cleared, we could see a large snowball in the vitreous, but no retrochoroidal gonoma or vasculitis. In the meantime, left eye showed the snowball. So we revised the initial diagnosis from toxoplasmosis to idiopathic intermediate uveitis. In the course of disease, here you can see there is a developing ERM also, epiretinal membrane. Vision deteriorated further in the right eye. We have started her on Visalon, but as we taper, there was a recurrence of the disease. After the 6 weeks, vision was improved significantly to 6/13 and 18 in the right eye. So the diagnosis was both eye regressed vitritis with retina on, and there was no cystoid macular edema. She was in follow-up with us by having cataract in the right eye. Pediatric hematologist opinion was taken to start her on methotrexate, but recurrence was still present. So along with methotrexate, we have increased the dose of steroids also. As we used to step down the steroid, there was increase in the recurrence of the disease. So we have shifted her on adalimumab, and the vision improved to 6/24 and 10, and the left eye 6/9 and 6. She is actually a B51 positive patient, but does not have any oral or genital ulcer. Now the patient has been shifted to tocilizumab, and she has received tocilizumab 10 dose, and vision is 6/18 and 6, and in the left eye 6/9 and 6. And the patient is having idiopathic intermediate uveitis. For the discussion part, for the etiology in the infectious, we have toxoplasmosis and toxocariasis as the leading in pediatric cases. In case of non-infectious, JIA, and in case of masquerade syndrome, leukemia leads the etiology. For the treatment part, I would like to discuss local steroids. We have used local steroids, or we can use intravitreal steroids. We can use methotrexate has been approved for the use in intermediate uveitis. We can also give intravenous steroid and oral steroids to the pediatric patient, but it can lead to side effects like Cushing features and growth retardation. So we cannot give them for long term. So we have shifted to biologics. Anti-mucin necrosis agent, infliximab, abatacept, tocilizumab, and rituximab can be used, but in the under the cover of a pediatric rheumatologist only. The current approach is to treat the acute inflammation with rapid establishment of the steroid-sparing medications. Adalimumab has an FDA approved for the treatment of intermediate uveitis. Potential adverse effects such as increased risk of opportunistic infection, malignancy should be carefully weighed against the benefits of the biologic therapy in the particular age group who has long life expectancy. Vitrectomy is an option for diagnostic as well as therapeutic purpose, but only in special cases like epiretinal membrane or media clearance, or in the case of the epiretinal membrane and macular holes. Thank you. These are my references. Thank you.
Which local steroid did you use in this case?
We haven't used any local intravitreal steroids.
That's precisely my question. Why you did not use any local steroids in this case? No PST, no Ozurdex. Why?
Invasive. Patient was not willing for any invasive procedures.
See, adalimumab is much more invasive when you talk about the drug. I hope you must have read the inserts
Literature.
of both adalimumab and tocilizumab.
She was taking subcutaneous.
patient has to give a very long consent for this. And
Every
there's
2 weeks she was taking adalimumab.
and there's a definite risk of B cell mediated malignancies when we give these drugs.
TNF
While we
alpha.
cannot treat it with a peribulbar steroid or a injection.
We have given them option, but they were not willing. So, and
See,
for adalimumab, this.
at the end of the case, it's a Behçet's which had trauma just like that. So that is what you're dealing with. Your baseline diagnosis should be Behçet's. So for management of Behçet's, switching on to adalimumab at 7 years of age, you'll have to maintain
7 years. It was a long course of disease. We shifted around 9
9
to.
9 to 21 you have to keep the
Ah.
patient on adali. So the cost and the invasiveness of the disease treatment is a bit more compared to what the disease could have been
She is
managed.
on tocilizumab. Yes, sir.
Mention azathioprine as one of the choice agents. In fact, azathioprine is a better tolerated drug in this age group when you are looking for long-term results.
Actually, drug was selected as per pediatric rheumatologist. We have suggested them. We have referred this patient to them. We need a rheumatologist opinion because she's a pediatric patient. We can't do on our own.
Okay.
So it was as per pediatric rheumatologist.
That's all.
Thank you.
Now we have the pleasure of inviting Dr. Sangeet Mittal to present his Nursing A Rao Award paper, Homemade Do-It-Yourself Aqueous Sampling Device for NTA Chamber Tap in Endophthalmitis.
So good afternoon, everyone. So
It is very interesting to see his videos. No,
good afternoon, everyone. I'll be presenting on a homemade do-it-yourself aqueous sampling device for anterior chamber tap in endophthalmitis. So endophthalmitis could be post-operative, could be post-traumatic, endogenous or secondary to keratitis, and a rapid diagnosis and appropriate treatment is required to save the eyes from irreversible blindness. So accurate, appropriate, and adequate sampling is the key to precise microbiological diagnosis. So the various specimens that we can have are vitreous tap, vitreous biopsy, or vitrectomy fluid, which is more sensitive, but it has to be performed in operation theatre, and a retina specialist is needed to do that. So considerable time is lost before initiating the treatment, leading to further growth of organism inside the eye and cause worsening of condition. So aqueous tap can be done by a comprehensive ophthalmologist and can be done before referring the patient to a retina specialist. The purpose of this study was to compare the aqueous tap performed by novel aqueous sampling device with conventional sampling method using 26-gauge needle mounted on a tuberculin syringe, and to compare the sensitivity results of aqueous sampling device with vitreous biopsy. It was a randomized controlled clinical trial. So this is how traditionally the sample is taken. You introduce on a tuberculin syringe, you mount a 26-gauge needle, and then you insert that needle into the aqueous chamber and withdraw the aqueous fluid. But the problem is that the eye need to be, if you are doing it under topical anesthesia, the eye need to be held by an assistant, and there's a lot of cumbersome doing it. So we devised a new method. This was a 2 cc syringe which was cut, the flanges were cut, and it was a rubber suction cup was attached to the top of the syringe. The 26-gauge needle was mounted on the syringe, and this is a demo you see. When you press the bulb and you release the bulb, the fluid collects into the syringe. This is the live demo of the same procedure. You insert the needle after pressing the bulb, and then you slowly release the bulb, and you can get an adequate sample into the syringe, as was obtained in this patient. So there was 40 clinical diagnosed cases of endophthalmitis, which were divided in two groups. Group A, conventional technique using 26-gauge needle on a tuberculin syringe, and group 2 was this novel device, using this novel device. And all samples were collected by ophthalmologists in operation theatre under peribulbar anesthesia. Aqueous tap was followed by vitreous biopsy and injection of intravitreal vancomycin and ceftazidime. After collection, samples were sent to laboratory for immediate inoculation and gram stain. So positive result means organism detected on either gram stain or KOH stain or culture. Results were also compared with vitreous biopsy to rule out any false positives. So the groups were evenly matched, and we got a significant difference. Like in the positive result, we got only in 3 patients with the conventional technique, whereas in the 9 patients we had a positive result. And when we matched it with the vitreous biopsy, the difference between the positive result of the vitreous biopsy and the result with the conventional technique was much higher, as compared to the aqueous sampling device. So the aqueous sampling device was found to be more accurate, more sensitive, but the specificity was the same as with the conventional technique. So adequate sample was obtained. There was no need of an assistant. Sample can be obtained by comprehensive ophthalmologist. Sample can be taken without delay at a primary center. Positivity is comparable to vitreous biopsy, and this whole instrument can be prepared immediately or can be pre-prepared and sterilized for a later use. The limitations were that it was a small sample size and it was not a blind study. So though vitreous is the best source for obtaining a specimen for culture or smear examination, the aqueous sampling device is easy to use, and an aqueous sample is obtained using it before giving an intravitreal antibiotic by primary ophthalmologist. It gives adequate positive results, thus avoiding delay in treatment and worsening of the disease. Thank you. Thank you. Thank you.
You can ask if she is in Nida Khan.
After this, we have to conduct semi-final also.
Do we have Nida Khan?
Dr. Nida Khan, she is presenting for semi-final session. Her topic is efficacy of adalimumab in non-infectious uveitis, a study at tertiary care center in South India.
Good morning, everyone. I will be presenting on efficacy of adalimumab in non-infectious uveitis. Uveitis accounts for nearly 10 to 25% cases of legal blindness in developing countries. Resistance to conventional therapy, drug-related adverse effects pose a significant barrier. Biologics have been a useful substitute for treating these cases. Adalimumab is a fully humanized recombinant monoclonal antibody which is directed against TNF-alpha. In July 2016, adalimumab became the first and only biologic approved by the FDA after the two trials, Visual 1 and 2, which was followed by Visual 3 study. However, in a country like India, the use of biologic agents is feared to be more prone to developing infections. We conducted this study to describe the treatment outcomes of adalimumab in non-infectious uveitis. It was a retrospective observational study conducted between 2017 and 2023. Electronic medical records of all non-infectious uveitis patients who received adalimumab were analyzed. Patients with infectious uveitis and a follow-up duration of less than 6 months were excluded from the study. The indication were inadequate response to immunotherapy, intolerance to immunotherapy, and for control of primary systemic disease. The criteria for treatment success was control of inflammation, significant decrease in disease recurrence, vision improvement, and vision stabilization. Appropriate investigations were done wherever required. Non-response to immunosuppressive was regarded as deterioration or persistent inflammation for 3 months with the use of immunosuppressive. A decision to administer adalimumab was decided either as first-line therapy or after non-response to immunosuppressive was made after consultation with rheumatologists, but primarily at the discretion of ophthalmologist. Appropriate statistical tests were applied, and p-value of less than 0.05 was taken as statistically significant. To the best of our knowledge, this is the largest study involving adalimumab in India conducted, involving 43 eyes of 26 patients with 12 males and with 14 males and 12 females. The mean age at adalimumab treatment was 18 years, and the mean age at diagnosis of uveitis was 14 years. Anterior uveitis were diagnosed in 11 eyes, intermediate in 5, anterior with intermediate in 12, and pan-uveitis in 11 eyes. The mean duration of follow-up was 19 months. Only 4 patients received the first-line therapy, while other patients already had received some immunosuppressive therapy. The most common diagnosis was JIA, followed by Behçet's, VKH, and the least common was Crohn's. The course of uveitis was complicated by various complications in these patients, including posterior synechiae, cataract, BSK, CNVM, CME, RD. Nearly 23% eyes required some surgical intervention due to these pre-existing complications. Adalimumab monotherapy was considered in only 1 patient. Oral steroids could be stopped in 12 patients, and oral steroid dose was reduced to 2.5 mg per day in 8 patients. Disease inactivity was achieved in 97.7% of the eye at last visit, and remission was achieved in 32 eyes at 3rd month. BCVA improved from 0.45 to 0.24, which was statistically significant. Overall, vision was improved in 21 eyes, it remained same in 16 eyes and worsened in 6 eyes. Drug had to be discontinued in one patient due to financial constraint, and relapse was seen in 2 patients. No systemic or adverse reaction was observed during our study, and only one patient developed some raised liver enzyme due to concurrent methotrexate therapy. This is a photograph of one of our patients showing before and after treatment with adalimumab. The management of non-infectious uveitis is a dynamic field. Effectiveness of adalimumab in JIE-associated uveitis has been well demonstrated by Sycamore and Adjuvant trial. Accessibility and affordability of biologic therapies in a resource-limited country like India remains a challenge, limiting their use. Likewise, in one of our patients, the treatment could not be continued due to financial constraint, and he had to be shifted to oral methotrexate. The EULAR has given anti-TNF alpha as the first line for BSETs-associated uveitis. In our series, 3 patients with BSETs responded very well. In our series, 1 pediatric patient with Crohn's disease required adalimumab. None of the patients in our study developed some new complications. Although adalimumab has a lower rate of recurrence, but relapse can still occur. In our study, relapse was seen in only 2 patients. Our study had certain limitation. It has a small sample size. However, ours is a tertiary referral eye care center that often caters difficult to treat patients with uveitis, frequently presenting late in the course of disease. And the mean duration of uveitis from symptom onset to presentation was 46 months. Quantitative evaluation of inflammation was not done in our study. To conclude, adalimumab was found to be effective in the treatment of non-infectious uveitis by achieving uveitis remission, reduction in recurrence rate with subsequent improvement in best-corrected visual acuity. The drug is safe and well tolerated as we did not encounter any systemic infection. It has a corticosteroid sparing effect. Thank you.
What is the cost and how many days you prescribe the drugs?
I think 6,000 per dose it is.
Right. Okay, so very nicely presented, but one of the main caveats when we treat with any of the biologics is that it is not sure shot that 100% of your patients will respond. So with adalimumab, the ratio of patient is 70 is to 30, that 70% of the patient respond and 30% patient just do not respond because their cell lines which are affected by adalimumab are not the ones which are responsible for causation of the disease. But in your case, it appears that all 42 patients?
Yeah, 42 eyes, yeah.
All 42 responded very well. So how do you explain that? You did not have to switch between the biologics in any of the cases?
Sir, most of the patients, most of them were already treated with some or the other immunosuppressive therapy.
No, I'm not talking of immunosuppressive. See,
yeah. So 97% we got at the last visit. So it was the 97% at the last visit. That was the one. And at the third month we saw the remission. It was 74% patients. Yeah, the remission was achieved in 74% patient at third month. That is what I told.
74%.
Yeah.
So that part one has to be, the message should be very clear that adalimumab is not a panacea for all uveitis. It is for a subset of patients, and still when you treat with adalimumab, few patients will be met with failure, and when you see a patient with failure, switch to another biological.
Okay, how many days you given treatment for remission for this?
How many?
What are the doses and how many days duration?
Sir, it was different for different patients. Actually, I've also mentioned the average number of injections which we gave. I'm unable to recollect, it's mentioned in one of my slides actually. But it was when the patient was responding well, we increased the gap between, like we started with 2 weeks interval, but when the response was good, we, with the consultation with rheumatologists, we made it 3 weeks or 4 weeks gap, reducing it.
Okay.
When you decide that you have to start adalimumab?
Like non-response to immunosuppressive therapy after 3 months of duration and persistence of inflammation, then we shifted the patients to adalimumab.
And about the treatment, like
including steroids plus and other immunosuppressives like azathioprine or methotrexate.
Okay.
Thank you.
Topic is sarcoidosis. Correct. Sarcoidosis and tuberculosis conundrum. Roll up serum AC, Mountex test, and lymphocyte count. Okay, for the sake of completion, you can present one more time for semi-final session.
We know it's very taxing, but you have to do it.
Good afternoon, everyone. I'll be presenting on the sarcoidosis tuberculosis conundrum and the role of serum ACE, MAN2, and lymphocyte count. Ocular TB and sarcoidosis are two diseases with overlapping clinical features, and differentiating one from the other is a challenging task. They are even postulated as opposing presentations of the same disease spectrum. ACE, MAN2, and lymphocyte are very commonly used in practice, but there is a lot of overlap in results in sarcoid and TB, and sensitivity and specificity of these tests vary in different study populations. Studies depicting their utility in combination are scarce and are very relevant in TB endemic countries like India. Our study attempts to address this lacunae in the literature. The purpose was to evaluate the diagnostic utility of serum ACE, MAN2 test, and lymphocyte count, both in isolation and combination in the diagnosis of ocular TB and sarcoidosis. The outcomes were sensitivity, specificity, positive and negative predictive value. This was a prospective observational study done for 2 years in Aravind Hospital, Pondicherry, in 95 patients with acute uveitis of age more than 18 years. We excluded patients with history of trauma, immunosuppression, use of ACE inhibitors, and steroids and immunosuppressants. We used the revised IWS criteria for sarcoidosis, and we used the Gupta et al. Criteria for diagnosing ocular TB. ACE was estimated using a substrate FAPPG. We analyzed 118 eyes of 95 patients. Ocular TB was seen in 12% of the study population, and sarcoidosis was seen in 20% of the study population. ACE was elevated in 89% of the sarcoid group and only in 33% of the TB group. The mean value was 76.2, which was statistically significant compared to that of TB. MAN2 was positive in 58% of the TB group and only in 15% of the sarcoid group. This was also statistically significant. Lymphopenia was seen only in the sarcoid group, and this was seen in 10%. None of the other groups had samples having lymphopenia. Elevated AC had a very good sensitivity and negative predictive value in detecting ocular sarcoidosis. Also, negative MAN2 had a very good sensitivity and negative predictive value, but their specificity and PPV was less. Also, as lymphopenia was seen only in the sarcoid group, the specificity and PPV became as high as 100%. Also, when we combined the three parameters, the specificity and PPV was as high as 100%. In ocular TB, we analyzed the role of both elevated and non-elevated ACE, and they both had a high NPV, and there was an overlap. Positive MAN2 had a very good negative predictive value in detecting TB. The area under ROC curve was maximum for elevated ACE when compared to that of lymphopenia and MAN2, and this was statistically significant. In ocular TB, the positive MAN2 had a very high AUROC of 0.835, which was also statistically significant. The strengths are, this is a prospective study where screening is done by a single trained observer, and to the best of our knowledge, no study conducted so far has tested the combined utility of elevated ACE, negative MAN2, and lymphopenia in the diagnosis of ocular sarcoidosis. Our study also analyzed the utility of serum ACE in ocular TB. This is an observational study where consecutive patients were enrolled, so there was no randomization. Also, study period included the peak phases of COVID pandemic, so viremia due to coexisting or previous infections could have affected the lymphocyte values. There were no biopsy-proven cases. Subjects included were either presumed or probable sarcoidosis and probable and possible ocular TB. What this study adds to. There was a study by Elango and Bishwas et al. From South India which said ACE was an independent risk factor rather than lymphopenia or when used in combination. A study by Philippine Court et al. Says combination of ACE and lymphopenia demonstrated a better diagnostic performance than these tests used alone. According to our study, combination of these three parameters, that is elevated ACE, a negative MANTO, and lymphopenia, had a better ability to diagnose ocular sarcoidosis owing to high specificity and PPV than these tests in isolation. Also, as the NPV is very high, in subjects with normal ACE, further screening for sarcoidosis may be required only if clinical suspicion is high. Even though AC was elevated in some patients with ocular TB, it may not serve as a useful screening or diagnostic tool in detection of TB. Also, as NPV is very high in case of negative MANTO, further screening for TB may be necessary only if there is a strong clinical suspicion. Serum ACE level assay is a better test for discriminating ocular sarcoid when compared to negative MANTO and lymphopenia in discriminating sarcoid from other diagnoses. Also, MANTO is a better test for discriminating ocular TB from other diagnoses. These are my references. Thank you for listening again.
Again, nice presentation. Just one last question, that when you are interpreting the results of MANTO test, what history should you take from the patient regarding previous testing before you comment on the outcomes of negative MANTO or a positive MANTO test?
Yes,
Is there some history regarding previous testing that you should take from the patient?
Yes, sir. In our population, there is a high false negative for so the BCG vaccination history and immunosuppression can affect the...
See, what happens that most of the time, I believe you are working in a tertiary care center.
Yes.
So a patient must have undergone a MANTO test in past 2 to 3 years.
Yes, sir.
So once
can
the patient has been tested,
Yes.
and you retest the patient in next 18 to 24 months,
Yes, sir. They can
you
be
will get a falsely
positive.
high MANTO
Yes, sir. Yes, sir.
reactivity.
Yes, sir.
So that part should be brought out in
Yes,
the
sir.
outcomes.
Okay, thank you.